My PhD topic is procalcitonin guidance for optimal antibiotic therapy in critically ill patients. My name is Márton Papp. I'm an anesthesiology specialist in Szent János Kórház in Budapest. My vision is that unnecessary and inappropriate antibiotic therapy will be a bad memory one day, and to achieve my mission is to protocolize and individualize procalcitonin use in clinical practice. Here are my specific goals. My first goal is to investigate the effect of procalcitonin-guided antibiotic therapy versus standard treatment in ICU patients with the methodology of a systematic review and meta-analysis of randomized controlled trials. We know that inappropriate use of antibiotics has serious adverse effects like emerging antibiotic resistance, direct toxic effects, and antibiotic resistance caused approximately 700,000 deaths worldwide in 2014. But on the other hand, the current guideline recommends us to give early the antibiotics immediately, but ideally within 1 hour of recognition of sepsis. We know that we can reduce the length of antibiotic therapy with the use of PCT with a median of 2 days, but it is still unclear when to start and stop the antibiotics and whether this PCT-guided management can serve this purpose. So our aim was to investigate the effects and safety of PCT-guided management versus standard treatment on appropriateness and length of antibiotic therapy. So our question is that does procalcitonin-guided antibiotic therapy reduce the length of antibiotic treatment without causing harm to our ICU patients? Our patients are adult patients in the ICU treated with antibiotics. Intervention is PCT-guided antibiotic therapy, which means there is a protocol for starting and or stopping antibiotics regarding PCT values, and this is a recommendation for the clinician. The comparator is standard of care without PCT guidance, and the outcomes are length of antibiotic therapy, rate of recurrent and secondary infection, ICU in-hospital stay, and mortality. And our hypothesis is that PCT-guided antibiotic therapy reduces antibiotic usage without compromising patient outcomes, and with reducing antibiotic use, we can reduce antibiotic-associated adverse events and healthcare costs without serious adverse effects. We conducted a systematic search with this search key in the 3 main databases, and after the selection we have 52 articles. Here you can see our primary outcome, which is the length of antibiotic therapy. As you can see, the data is quite heterogeneous. These are 20 RCTs with more than 8,000 patients. The effect measure is mean difference in days, and the effect size is minus 1.79, which means that PCT guidance decreases length of antibiotic therapy with nearly 2 days, which is clinically relevant and even statistically significant. We made a subgroup analysis for sepsis definitions because sepsis 1 and sepsis 2 was very aspecific. As you can see, defined sepsis as a systemic inflammatory response syndrome which is caused by an infection, but the SIRS criteria is quite aspecific for infection, and many other insights like pancreatitis trauma can cause SIRS. In spite of that, the sepsis 3 definition says that sepsis is a life-threatening organ dysfunction which is caused by a dysregulated host response to an infection, which emphasizes the organ dysfunction and the dysregulated host response. If we look length of antibiotic therapy with this subgroup, you can see here that in sepsis 3 patients, the decrease of length of antibiotic therapy is even higher. It is nearly 4 days, which is clinically highly relevant. Our safety outcome was rate of recurrent infection, which is important because hypothetically, if we stop antibiotics earlier, we risk the recurrence of the primary infection. And you can see here the outcome measure is odds ratio, and the effect is 1.58, which means that the odds of infection recurrence is 1.6 times higher in the PCT-guided group compared to usual care, which is clinically relevant and statistically significant. Our other safety outcome is 28-day mortality with 22 trials over 7,000 patients. And you can see here that the odds for 28-day mortality is nearly 15% lower in the PCT-guided group compared to usual care, which is clinically relevant and statistically significant result. And if you look again for the subgroup analysis, in sepsis 3 patients, this decrease is even more pronounced. The mortality is halved, and in respiratory tract infection, the mortality is decreased by 40%. Both of the results are clinically relevant and statistically significant. If you look for the rate of secondary infection, which is a new infection caused by another pathogen than the first one, the boxes are both of the sides of the vertical line, and if you can see the results and the confidence interval, we can't really say if there is a difference in the rate of secondary infection. We looked for the length of ICU stay, which is nearly 1 day decreased, and the length of hospitalized stay, which is decreased by nearly 1.5 days. Both results are, I think, clinically relevant, but statistically not significant. The strengths are that we only used RCTs with a high number of articles and high number of patients, but with high heterogeneity and different degrees of protocol violations in the studies. But for conclusion, we can say that we can reduce antibiotic use with PCT guidance, but it is accompanied by higher rate of infection recurrence. Despite of that, this is associated with a lower 28-day mortality, and in sepsis 3 patients, the decrease in antibiotic use and mortality is even more pronounced. Implication from practice that we should use procalcitonin and clinical evaluation for guiding antibiotic therapy, but we need RCTs for starting antibiotics, and we should use organ dysfunction as outcome rather than mortality. I am now writing the manuscript, as you can see. And my second goal is to investigate PCT kinetics to guide antibiotic therapy in ICU patients with suspected new onset infection with the methodology of a randomized controlled trial. We know that every second ICU patient considers as infected, but infection can more than double ICU mortality. On the other hand, less than 60% of our ICU patients are, with an initial diagnosis of sepsis, are confirmed to have an infection. So, diagnosis of infection could be quite challenging. We know that procalcitonin is the best known sepsis biomarker. Even after a prolonged ICU stay, we can use it. And we can use either absolute PCT values or the kinetics of procalcitonin, but we don't know which one is a bit better predictor of the infection. So our aim is to investigate whether antibiotic initiation guided by PCT kinetics can decrease unnecessary antibiotic therapy compared to using absolute PCT values or no PCT at all. So the question is that can we decrease the use of clinically unnecessary antibiotics with the help of procalcitonin kinetics in ICU patients? Our patients are adult ICU patients with a suspected new onset infection. The intervention 1 is antibiotic initiation using PCT kinetics. Intervention 2 is antibiotic initiation using absolute PCT values. And the comparator is antibiotic initiation without the PCT guidance. And our outcomes are rate of unnecessary antibiotic therapy, rate of recurrent infection, organ dysfunction, and mortality. And the hypothesis is that using PCT kinetics can reduce the rate of unnecessary antibiotic therapy without compromising patient outcomes, compared to using absolute PCT values or usual care only. And with decreasing the antibiotics, we can decrease the antibiotic-associated adverse events. And now we are at the preparation of the protocol at the moment. Here you can see the overview of my goals, and thank you for your attention. My quote is, "He who fights can lose, but he who doesn't fight has already lost." Thank you.
Congratulations, Marci, for this very nice comprehensive work. My question would be that, as you are already a specialist, what is your common clinical practice at St. John's Hospital, and do you use, or how frequently do you use procalcitonin guidance?
Yeah, thank you for your question. I can see that we use regularly. If the patient has an infection or we think that he has an infection, we use it on a daily basis in every 24 hours. It can help us for starting the antibiotics, and it can help us to guide the antibiotics to see if the antibiotic which we are giving is good. That's one question. And if the antibiotic is good, when we must or when we have to say that it's enough, we are treating the infection, we can stop the antibiotic. So we use it on a regular basis. And it helps a lot, I have to tell you. Thank you.
Hello. Thank you for the nice presentation. I would like to ask one thing, that what do you think the reason is for the increased rate of recurrent infections and despite of that lower mortality rate?
Yeah, I guess the results are very straightforward. Every trial has the same result. That in the PCT-guided group, the recurrence of the primary infection is higher, but this doesn't add to the mortality because these are not very difficult pathogens to treat. According to, or in opposite, when we talk about secondary infection, in that case we talk about mostly in multi-drug resistant organism, which comes with a higher mortality, and they are very difficult to treat. And I have to add that in some articles they even say that maybe there is a bias because the clinicians was not blinded, and they thought in the PCT-guided group that yes, this infection is because we stopped the antibiotic too early. So it may be more than one explanation for this.
Thank you.
Thank you for the presentation. In the beginning, you highlighted the surviving sepsis guideline recommendation of early initiation in the first hour, the antibiotic therapy. And do you think, based on your suggestions, that the kinetics of procalcitonin, the build-up kinetics, can be so fast and so reliable compared to, for example, troponin, that in this 1 hour or 2 hours range, could it help the decision, or it's slower and dependent on more factors?
Yeah, the question is very good. The kinetics of procalcitonin is slower than troponin. We know that because there are a lot of studies that we know that it rises until 16 or 43 hours one day and then start to decline if the antibiotic therapy is good. But in our project, we would like to measure procalcitonin between 24 hours. And that's the plan, that if we see different patterns during these 24 hours, we can make our decisions regarding that. 1 or 2, this 1 or 2 hours is enough for us to measure PCT. But for example, if we have a patient from an internal medicine departure and have a PCT there from the previous day, we have, if the patient is stable, we have 3 hours regarding the guideline. We measure the PCT and then look for the 2 measurements, and this can help our decision whether to start or not antibiotics.